Today we're examining a clinical investigation into a powerful connection, the relationship between jaw surgery and speech correction. We'll be exploring how orthognathic surgery, when combined with dedicated speech therapy, can offer a definitive solution for certain long-standing articulation disorders in adults.
So this brings us to a fundamental clinical question. Why is it that some adults, despite years of speech therapy, continue to struggle with misarticulation? Well, this study posits that the answer might not lie in the therapy itself, but in the patient's underlying anatomy, a physical, structural barrier that therapy alone simply cannot overcome. To understand this fully, we'll proceed through 5 distinct sections. First, we'll define this anatomical barrier. Second, we'll review the integrated treatment protocol used in the study. Third, we'll analyze the quantitative logopedic outcomes. Fourth, we'll introduce a novel classification of consonants. And finally, we'll discuss the interdisciplinary conclusion and its implications.
So, let's begin with the foundational problem. When speech therapy proves ineffective, it becomes necessary to look beyond functional habits and investigate the physical structures responsible for articulation. The specific condition at the heart of this issue is known as skeletal malocclusion. Now, this is more than just an orthodontic issue of tooth alignment. It's a significant misalignment of the jawbones themselves. This creates a literal physical impediment that prevents the tongue and lips from achieving the precise positions required for clear speech.
And the effects of these skeletal deformities are not limited to speech. They often compromise the most basic oral functions, including breathing, swallowing, and chewing. These are the very biological processes that provide the foundation for normative articulation.
It is essential to remember that speech is an overlaid function. We don't possess a dedicated organ for speaking. Instead, we utilize the anatomy of our respiratory and digestive systems, the stomatognathix system. It logically follows, then, that any structural defect within this system will inevitably result in speech distortions.
So, given that the problem is fundamentally structural, the proposed solution must also be structural. This leads us to the multimodal treatment protocol detailed in the study, which combines surgical intervention with therapeutic rehabilitation.
The patient's journey through this protocol involves 3 critical phases. It begins with orthodontic decompensation, which prepares the teeth for their correct post-surgical position. This is followed by the orthognathic surgery itself to correct the jaw alignment. Finally, post-surgical logopedic therapy is crucial to retrain the oral musculature to function within the newly corrected anatomical framework. Achieving a successful outcome requires a truly integrated interdisciplinary team. It necessitates the coordinated expertise of a maxillofacial surgeon, an orthodontist, a speech pathologist, and often a physiotherapist. It is only through this collaborative effort, combined with the patient's commitment, that the desired outcome can be achieved.
Now, let's turn to the results. What were the measurable, quantitative effects of this protocol on patient articulation?
This first chart displays the scores for what is termed total lips efficiency. As you can see, there is a statistically significant improvement in lip motor skills following the surgical correction. By removing the skeletal barrier, the surgery facilitates far greater neuromuscular control of the lips, which is a prerequisite for proper articulation of many sounds.
The improvement becomes even more pronounced when we examine specific phonemes. This chart illustrates the pronunciation quality for dental consonants. Again, we see a dramatic improvement post-operation. The correct production of these sounds is highly dependent on the relationship between the tongue, teeth, and jaw, which is precisely what the surgery normalizes. However, the data also reveals a degree of nuance. The effectiveness of the treatment is influenced by the patient's specific pre-existing dental condition. For example, outcomes are significantly better in cases of simple dental crowding compared to more complex open bites. This underscores the multifactorial nature of articulation. This analysis leads us to what is perhaps the study's most important contribution, a new conceptual framework for classifying consonants, which provides deeper insight into the mechanics of these particular speech disorders.
The researchers propose 2 distinct categories. First, skeletal consonants, which are sounds whose articulation is primarily dependent on the underlying bone structure of the jaw and palate. In contrast, soft tissue consonants are those produced mainly by the independent action of the lips and cheeks.
This is not merely a theoretical distinction. As you can see in this factor analysis plot, the pronunciation data from the patients reveals 2 statistically distinct clusters of consonants.
This empirically validates the concept that sounds can be grouped based on whether their primary articulator is bone structure or musculature.
And here is the clinical confirmation. The data clearly demonstrates that a Class 3 skeletal deformity significantly impairs the production of skeletal consonants. Crucially, it does not have a statistically significant effect on the soft tissue consonants. This provides direct, compelling evidence of a causal link between a specific anatomical defect and a specific category of speech error.
So let us synthesize these findings into a coherent clinical conclusion. What are the practical implications of this research for patient care? There are three key findings. First, skeletal malocclusion represents a true physical barrier to correct articulation. Second, this explains why traditional speech therapy alone is often insufficient for these patients. And third, it establishes that surgical correction is often the essential enabling step that creates an anatomical environment in which subsequent speech therapy can finally be effective.
The study's conclusion is stated unequivocally. Orthodontic preparation with surgical correction of malocclusion is often the only approach that helps to improve articulation. This reinforces the central thesis that for this patient population, an integrated surgical approach is not just an option, but a necessity.
This research leaves us with a final, forward-looking question. How might this integrated treatment model and the insights gained from it redefine the conventional boundaries between dentistry, surgery, and speech pathology when treating patients with complex articulation disorders?